The Economic Times today, the 28th of July 2020, has reported that yesterday only 26 people died in the city of Delhi. No person has died during isolation. Probably they were provided oximeters, so when or if the oxygen dropped, these people rushed to hospitals where they were treated adequately. So the good news is that apart from new cases, even deaths have rapidly declined in Delhi. The Indian Express has reported yesterday that the decline in deaths in Delhi is to the tune of 45%, as opposed to June. In July, deaths have gone down from 100 per day to just about the 30s in July. So this is very good news for us in Delhi. As opposed to Delhi, there has been a spike in new cases in Spain, which has prompted the British government to slap a quarantine on people returning from Spain. The quarantine lasts for 14 days, and this is a big blow to the tourism industry. The tourism industry is up in arms. It is quite irate because it understands that the impact will be damaging to the tourism in the United Kingdom. Therefore, the British government is very keen on reducing the quarantine period from 14 days to just 10 days, a reduction of 4 days, in trying to get some balance for the tourism industry. The rationale behind reducing the quarantine from 14 to 10 days is the fact that about 2 months back, a paper was published in the Annals of Internal Medicine, which showed that false positives in a PCR test were as high as 100% on the day of infection. This means that if you knew the day you were infected and got yourself tested by the RT-PCR, and if you turn out to be negative, that would be 100% wrong. You were actually infected. Now this false negative fell down to just 68% on day 4 after a person got infected. And on the day of symptoms, which usually is 5 days, because that is the almost the incubation period, on the 5th day, that is when the symptoms developed, the false negativity was down to just about 38%. And on the 8th day, the false negative tests were down to just 20 or 22%. So this means that the best time to do an RT-PCR on a person is about 8 days from the onset of infection or 3 days after the onset of symptoms, because that's the time when a test, if negative, would be true by 80%. Only 20% of those negative tests would be truly negative. And after that, again, there was a swing upwards. That means the false negative tests went up. So therefore, by the 21st day, the false negative tests were up back to 67 or 68%. Now this data is very relevant, and it is on this data that the British government will test people on their arrival to England from Spain on day 8th, and presuming that they get the results in 2 days, the quarantine will be restricted to 10 days. If they turn out to be negative, then there would be a fair chance that they would be allowed to go back to their work. One of my colleagues, junior colleagues, mentioned today on the rounds that he had become infected. He was RT-PCR positive, and then later on he became negative. And would he or should he do another test 15 days down the line? So I said no. I discouraged him. I said there's no point. The fact that you've turned negative means that most probably the virus has stopped replicating. The fact that you are working in the hospital after almost a fortnight of your onset of symptoms means that even if the virus is inside your body, it is not infective any longer. Now we switch from the RT-PCR and the false negativity to cardiac involvements of COVID-19. The fact is now that It is well accepted that COVID-19 is no longer a lung disease only. Undoubtedly, it penetrates the body via the lungs, via the oropharynx and then to the lungs. It does infect the lungs in a great deal of patients. But apart from that, it also infects other organs like the brain, the kidneys, and of course the heart. In my last video, I had mentioned this case report of a 43-year-old woman who became infected. She had no prior history of any fever or cough. She came with a heart attack. The angiogram showed that the arteries were normal. They were not blocked. She was put in the ICU because she developed hypotension. But sadly, in about 46 hours, she died despite intubation and being attached to a ventilator and despite every kind of therapy, which included heparin in high doses, prednisolone, and also immunoglobulins. The autopsy was done, and surprisingly, it was found that the woman, the heart, had no myocarditis, had no virus, but had multiple tiny clots in the microvasculature, that is, the tiny vessels of the heart which supply the heart muscles, and therefore she developed the heart attack. Now, this is a single case report. Of course, there are other cases also, and there are reports on autopsy that there are multiple microclots in the heart, but these are not very many. Now we have two big papers which have been published yesterday in JAMA. Both are from Germany. I'll talk about the first paper. This is an autopsy report of 39 people who died. The median age was 85 years. I think about 60% were women. What was found was that in 90% of these deaths, the cause was pneumonia. But, however, in 62% of these autopsies, it was found that the heart was infected by the Chinese virus, by the COVID-19 virus. This was seen under the microscope, and more importantly, there was no signs of any myocarditis. There were no sign of any lymphocytes, which suggested lymphocytic myocarditis. Almost 63% of these hearts, that is 24 of 39, had the presence of virus. And more importantly, almost 10% of the hearts had replicating virus, multiplying virus. So that brings up the question whether these people could have been infected from their heart, right? Could have been infective, from their hearts. So we have a situation, and that is what the researchers have discussed, that in 2/3 of people who are dying, the heart is affected by the Chinese virus. There was in this series no evidence of viral myocarditis, no evidence of lymphocytes, but the virus was seen not within the myocytes, not within the cells of the fibers of the heart, but in the interstitial cells and also in the macrophages. Within the macrophages, there was evidence of the virus. So this is important because we now have to keep in mind what would be the sequelae of a heart infected by the virus. The other paper is a larger paper. This one is from Frankfurt, from the University Hospital. What they have done is that they have compared 100 patients of COVID-19 to 50 people who have no disease but are matched by age and sex, and another 50 people who have no disease but have risk factors such as hypertension, heart disease, obesity, lung disease, and diabetes, and are also matched by age and sex. What they found out was very interesting. Of these 100 people who were infected, confirmed by a PCR test, 2/3 recovered in their homes, 1/3 were admitted in hospitals. The median age was much younger. It was about 49 years. Around 53-54% of the patients were males, but all of them had an MRI. Now that is the importance of this study. This is an imaging study where cardiac MRI was done in these 100 patients and the 50 normals and also the 50 people who had risk factors. So that means we have 200 patients with MRIs, and what was seen in the 100 people who had the MRI was that 78% of patients exhibited infection and ongoing inflammation by MRI, right? The exact figure of ongoing inflammation was 60%. That means 60 patients who were subjected to a cardiac MRI showed what are called T1 and T2 signals. There is a number for them. If the T1 signal exceeds 1000 milliseconds, that means there is edema and there is ongoing inflammation, and which could be reversible. So to repeat, in this study of 100 people, 60 people showed ongoing inflammation. The MRI was done about more than 2 months after the onset of symptoms. I think the median time was 71 days following the onset of symptoms. So after 2 months, it was found that 60% of these patients had ongoing inflammation, and 72% of these people, or rather 78% of these people, had some problem which was being seen, which was spotted by a cardiac MRI. The other important thing is we have what is called a late gadolinium uptake, which is a contrast. Now, if you can pick up a late gadolinium uptake in the cardiac MRI, that means there is scar tissue, which suggests that the problem has become irreversible. The hallmark of a myocarditis or an inflammation of the heart is that the scar tissue is seen beneath the epicardium, or rather in the middle of the heart muscle. When there is a heart attack, the classical heart attack because of an artery getting blocked, in that case, the late gadolinium scar is seen beginning from the endocardium, right? That is the heart muscle which is just adjacent to the lumen or the cavity of the heart. Now, I won't go into the details of this. It is suffice to tell you that in this study, almost 1/3 of patients had a late gadolinium uptake, which was seen in the subepicardium or the mid myocardium area as a white scar, and almost 20% of people also had gadolinium uptake of the pericardium. That means even the pericardium was involved in 1/5 of these patients. A few of these patients who were admitted also had what is called an endomyocardial biopsy. The biopsy was also very interesting. The biopsy did not show any virus, but it did show that there was lymphocytic inflammatory myocarditis going on. So there was lymphocyte infiltration of the myocardium, which was seen on histology, apart from the fact that the myocytes were dilated because of the ongoing inflammation and edema within there. But there was no fibrosis between the myocytes, as seen by histopathology. Now, these two studies should be juxtaposed, and as a cardiologist, I am very concerned because now it is becoming more or less established that the heart can be involved. It can be involved along with the lung involvement or along with the brain involvement or the kidneys being involved, but it can be involved all by itself. The other features of this Frankfurt study were that on echocardiogram and also by the MRI, the heart was slightly larger, it was dilated, the volume was increased, the mass was increased. That means the muscles were thicker because of the edema, and the ejection fraction was mildly lower. Not very much, but it was mildly lower. So now the questions crop up. What are the questions for a clinician? The most important question is whether these changes seen in the heart of patients of COVID-19, whether these changes are permanent or whether they are temporary. Now remember, if you get a viral myocarditis by other viruses like Coxsackie or adeno or rhino, those viruses, then a large number of patients recover over time. So, of course, there is matter of concern. This COVID-19 infection of the heart, it is a matter for concern, but I am optimistic. Of course, I have no evidence because there is no follow-up data, but it would be very interesting to see how many of these patients go on to develop further deterioration of their left ventricle function. Or to put it in simple English, how many of them go on to develop heart failure? For this, we have to have a longitudinal study. We have to assess these people later on after 6 months or 1 year. And also, the other questions that crop up are that, can we arrest this progress? Can we arrest this remodeling? Can we abort? Can we stop this ongoing dilation or inflammation in the heart? And if they do develop heart failure, do the conventional medicines work? Can we treat them as we treat other patients of heart failure following myocarditis? That means other cases of ischemic cardiomyopathy or non-ischemic cardiomyopathy with reduced ejection fraction. And of course, the most important fact is, or rather the most important question would be, if we do find after 2 or 3 months by a cardiac MRI that a person is having either a scar or is having ongoing inflammation, what medicines can we use? What medication can be employed to treat these people? Now, these are very, very important questions, and I'm sure researchers all over the world would be now looking very, very carefully at these facts. So to conclude, cases in Delhi have gone down. Deaths in Delhi have substantially come down, which is very good news. The English government is thinking of imposing a quarantine not of 14 days, but of only 10 days, because of the fact that they would like to test the people coming back on the 8th day after they enter the country, because on the 8th day, the chances of having a false negative PCR test would be very low, almost just about 20%. And then these people, if they turn out to be negative, can safely go back to work. The other thing is that we have now information. We have 2 classic papers. One is an autopsy study of about 39 people who died, and the other is a cardiac MRI study, including 100 patients who were confirmed, which has shown that people, a large number of people, more than 2/3 of people who get infected by COVID-19, even if they have mild symptoms, it is not necessary that they had severe symptoms, 2/3 of these people do or can be seen to have an effect of the virus on their hearts. This can be best picked up by a cardiac MRI, because the echo may not pick up this feature. The echo may pick up a slight fall in ejection fraction, but the actual inflammation or scar tissue produced by the COVID-19 infection can be best picked up by an MRI. So centers which have a cardiac MRI must now initiate a protocol by which all patients who can afford a cardiac MRI, or if these MRIs can be subsidized in patients of confirmed COVID-19 by RT-PCR or by antibody testing, I think it would be worthwhile trying to pick up patients who have their hearts affected, and then we get down to figuring out as to how to treat them at that point of time or how to treat them later on. Okay, thank you very much. I think I will finish it at this point.